Hello. This presentation is about an area of specialization that most people call perinatal psychiatry. The term mother-infant psychiatry has the advantage that the baby is in the title, and infant-related disorders are less likely to be neglected. The presentation is based on an international position paper published in 2017 with nearly 70 authors from 32 nations. It is concise, only 5,700 words, takes half an hour to read, and covers the need for the specialty, its knowledge base, the many settings for clinical practice, and the functions of the service. First of all, the need for clinical specialization. There are three reasons. First, the mental health services concerned with the pregnant and newly delivered mother have an equal responsibility for the child. This is not true of general psychiatry, which at its best takes account of parenting, but is not responsible for the children. And it's not true of child psychiatry, which must work closely with parents, but is not responsible for their mental health. The child is vulnerable because of its genetic background, disruption of parental relationships, and adverse psychosocial risk factors. The infant enters into a number of syndromes, as will be later explained. The unborn child has to be taken into account in many forms of treatment. The assessment of the mother's relationship with the fetus and the infant is a vital and the most specific part of the clinical investigation. These child-related features, together with the observation of mother-infant interaction and the care and safety of the baby, are peculiar to this branch of psychiatry. The second reason is that childbearing is attended by a multitude of psychiatric disorders, which make it the most complex event in human experience. The sheer number, variety, and range of disorders tax the knowledge of general psychiatrists. Now, some are common, the sort of disorders that any general practitioner would recognize, and some are rare, disorders that consultants and specialists should be aware of. But parents should have access to experts with comprehensive knowledge. That's the burden of a monograph published 25 years ago. Many chapters will be out of date, but there may be no other extant book which covers the whole field. Now, medicine is the highest aim, I beg your pardon, prevention is the highest aim of medicine, and identifying parents and infants at risk during pregnancy and the postpartum period offers exceptional opportunities for the prevention of parental mental illness and its adverse consequences on the development, behavior, and health of children. Now, turning to the knowledge base, I shall briefly mention about 60 disorders, each with its own features and interventions, and 30 of them will be presented in this first presentation, and the others in presentations on the psychoses and bonding disorders. But first, a word about rarity. Many rare disorders will be mentioned. Disorders appear to be rare for three reasons. First, because they are rare. Career psychosis used to be common enough, but because the streptococcus has not acquired resistance to antibiotics. It has now almost disappeared. Secondly, because knowledge has been lost. In the early 19th century, there were excellent descriptions of parturient disorders, which have hardly ever been cited. So they never entered, they never became diffused as knowledge. The knowledge was lost. And thirdly, because they're rare in high-income nations, but may be common in nations where most of the world's children are born. And an example of this is eclamptic psychosis. Now, the disorders of childbearing come under 6 headings. First, disorders of adjustment to pregnancy. Then other disorders, other complications of pregnancy. Then the psychopathology of parturition. Then postpartum psychiatric disorders under the headings of depression, anxiety and obsessional disorders, and of psychoses. And finally, the child-related disorders. About half pregnancies are not planned, and there are a number of different pathological and unusual responses to an unexpected pregnancy. In obese women and those close to the menopause, a child may be born unexpectedly, and this is a joyous event. But an unexpected pregnancy may be unwelcome, and if it is conceived out of wedlock or by adultery, it may be deliberately concealed. Alternatively, there may be dissociative denial, that is, the denial of pregnancy. The pregnancy may be acknowledged, but emotionally rejected. It may be ignored in mild cases with an absence of prepartum bonding, but in severe cases, there may even be fetal abuse. Some women are so embarrassed by their pregnant appearance that they develop ideas of reference and social avoidance, a form of dysmorphophobia. And finally, there are pregnant women who are so desperate to end the pregnancy that at any risk, the risk of prematurity to the infant, they importunately demand induction of pregnancy or perpetrate obstetric factitious behavior. Although 50% of pregnancies are unplanned, most are merely mistimed and accepted, but some are persistently rejected. The number varies a great deal between nations, but a figure of 10% would be approximately right. And this is a problem in many nations and countries of various religious faiths. And rejected pregnancy leads to complications during pregnancy, parturition, and the puerperium, especially disturbed bonding. There is an extensive literature on denial of pregnancy, and a series of excellent papers by Jens Wessel include a 12-month prospective study in which he collected 94 cases from obstetric units in Berlin and estimated incidence of 1 in 500 pregnancies diagnosed at 20 weeks postpartum, at 20 weeks gestation. But some pregnancies come to term without being diagnosed. And the frequency of unexpected births is about 1 in 2,500. Now, the psychiatric pregnancy includes prepartum depression and suicide, prepartum anxiety and its focus, various psychoses and the effect of prophylactic drugs such as lithium and valproate on the fetus, substance abuse including alcohol, narcotics and cocaine, eating disorders, and obstetric factitious disorder. Depression is just as common during pregnancy as after it, or at other phases of a woman's life. And the causes are also similar: marital conflict, social problems, and adverse events. The suicide rate used to be, and may still be, raised in unwanted pregnancy. Pregnancy is a time of great anxiety for many women, but the main focus depends on the stage of gestation. During the first trimester, it is the conception crisis, whether to continue or terminate. And during the second trimester, it is the fear of fetal loss, especially in women who have suffered from infertility or a recurrent miscarriage, or who have already suffered a fetal loss. And during the third trimester, there is the fear of malformations and of inadequacy as a mother and of tocophobia. Because of the effect of medication on the fetus, it is best that prepartum anxiety is treated by psychological therapies. Now, tocophobia, that is the fear of childbirth, is severe in at least 5% of women. It may be primary, leading to celibacy or deliberate infertility, or it may be secondary to a very severe birth experience. There has been extensive research into tocophobia in the Nordic countries, who have produced a self-rating questionnaire to estimate its severity, and there have been a number of treatment trials, and on the whole, counseling is an effective alternative to elective caesarean section. All drugs prescribed during pregnancy have effects on the fetus, which may include teratogenicity, intoxication of the newborn, or neonatal withdrawal syndromes. To take two examples, benzodiazepines cause what is called the floppy infant syndrome, and selective serotonin reuptake inhibitors can cause pulmonary hypertension of the newborn. Electroconvulsive therapy is on the whole safe, but can provoke premature labor. Ethanol abuse is teratogenic and results in the fetal alcohol syndrome. It also leads to intrauterine growth restriction. When a mother continues to abuse alcohol severely until parturition, the infant suffers a withdrawal syndrome. Narcotic abuse leads to premature births, low birth weight, and a withdrawal syndrome. Mothers should receive buprenorphine maintenance and social casework during pregnancy. Suppressing narcotic effects by naloxone is dangerous to the infant, and neonates may need benzodiazepines for withdrawal symptoms. Cocaine abuse has similar effects, but also leads to placental abruption and microcephaly. The withdrawal syndrome is less severe, but neonatal mortality rate is higher, including sudden infant death. Many women recover from anorexia nervosa and give birth, though fertility may be reduced. But pregnancy in women with eating disorders is a challenge. During pregnancy, they often improve, but many relapse postpartum. Pregnant women who continue to restrict food intake may harm the fetus. Anorexia and bulimia are sometimes associated with deviant mothering. Self-induced illness occurs in all sorts of circumstances, which include pregnancy, and women may simulate placenta previa, hydatidiform mole, pernicious vomiting, or fetal death in utero, and may pretend to be in premature labor. And they may induce premature labor. One woman self-induced labor by rupturing her membranes or by prostaglandin in 5 pregnancies. Now, turning to the psychopathology of parturition, most of these complications have now been eliminated in high-income nations with excellent obstetric services. But in sub-Saharan Africa and Southeast Asia, many women give birth without professional help and without effective analgesia. And their maternal mortality rate is greatly increased. And they may suffer from the complications which were described in Europe before the discovery of effective analgesia in 1847. They include parturient delirium, one of the first disorders to be described in the 18th century. And this may also develop immediately after the birth, as will be described in the second presentation. And then there is parturient rage. And this is a factor in some cases of neonaticide, where extreme violence is used to kill the newborn, smashing its skull or stabbing it many times. And there are acts of desperation, including auto-caesarean section, of which 22 cases have been described, or suicide. The murder of the newborn after a concealed pregnancy and a clandestine birth used to be a major public health problem, with infant corpses found all over the place. And it still occurs all over the world, even in nations with easy access to contraception and abortion. And there are over 80 reported cases of serial neonaticide. One Japanese mother killed 9 newborn infants. Even with excellent obstetric care in high-income nations, labor may be an ordeal, and there are complications of very severe labor. There's a report in the 1970s by Monique Bilovsky of the nightmare of childbirth. She wrote, "Parturition, especially the first, can, by its obligatory violence and by its confrontation with an imminent and lonely death, put the mother under extreme stress." And she found 10 cases in just over 4,000 deliveries. All had long, hard labors resulting in post-traumatic stress disorder and secondary tocophobia. And there are now 50 to 100 papers on obstetric PTSD, with a frequency up to 5% of births. There is another reaction to severe labors, not commonly mentioned, but almost equally common, and that is pathological complaining about obstetric management. The mother's bitterness is expressed in extravagant terms. I've heard 2 mothers say they felt like burning the hospital down. Its effect on childcare is similar to depression, but the effect is anger and not sadness. Treatment is by psychotherapy, diverting the mother's attention to positive activity, especially childcare. Now, when childbirth is results in the tragic loss of a child or to very severe abnormalities, the parents suffer shock and sadness, and sometimes anger and guilt, recrimination, and stigma. They must face friends, parents, and other children who may also be grieving. And sometimes they have hallucinations of the baby or even a temptation to steal babies. Staff need to know how to comfort bereaved parents, and bereaved mothers need skilled counseling. Turning to the puerperium, I should mention the maternity blues. About 50% of mothers suffer a brief period of dysphoria lasting usually just a few hours during the first 10 days after the birth. It is important to distinguish this from depression, especially the continuation of long-lasting unhappiness or demoralization due to difficult circumstances or relationships. This is not really a clinical disorder. These mothers only need reassurance that it is common and benign. Depression is a major consideration of specialist services in high-income nations and probably throughout the world. And almost all patients who are referred to services will be depressed to some degree. And this was first described early in medical history, in the 16th century, by a Portuguese physician. This is what he wrote in, of course, medieval Latin. The beautiful wife of Perinatal, who always enjoyed the best of health, was many times attacked by melancholia after childbirth, and remained insane for a month, but recovered with treatment. Now, the modern era was ushered in by the studies of the Gordons in New Jersey in the 1950s and early 1960s, and they emphasized social factors and recommended social casework. And since then, a flood of research has been published, most of it using self-rated screening questionnaires, which have found that about 25% of mothers in the community have high scores on questionnaires. But interviews are required to distinguish depression from other mood disorders and other sources of distress. And rigorous diagnostic studies show that only 6% have major depression, a frequency similar to the population. About half consult their general practitioners and are referred to services, and 1 to 2% are admitted to hospital. Depression is frequent in women of reproductive age, whether they are infertile, pregnant, postpartum, occupied in childcare, or menopausal. And on the whole, the symptoms and causes of postpartum depression are similar to depression occurring at other times. The term postnatal depression has become a chapter heading for a heterogeneous group of disorders which are often comorbid. Some of these mothers have other disorders more prominent than depression. A thorough interview study of over 200 mothers in Birmingham and Christchurch, which are called the Anglo-New Zealand study, found that 25% had at least 3 disorders, and a few had 5 disorders, for example, anxiety, depression, obsessional, querulent, and bonding disorders. The treatment of the mood disorder will always involve psychotherapy or cognitive behavioral therapy, and often antidepressant agents, which can be given safely to breastfeeding infants. Some mothers will require electroconvulsive therapy. It is important to explore the social and psychological factors underlying depression and to address these issues. Suicidal depression is one of the 3 most severe disorders met in this area of psychiatry. But suicide is not increased after childbirth. A Finnish register study found 30 suicides in just over 500,000 births, that is a rate of 6 per 100,000 per year, which compares with the Finnish female rate of 9 per 100,000 per year. But practitioners should be aware of the risk of maternal suicide to the infant. Combined suicide and filicide is the 2nd commonest cause of filicide after maltreatment. And studies of convicted mothers underestimate its frequency because most do not survive. A Danish study of 87 parents who poisoned their children, almost all mothers, found that 77 completed suicide. The postpartum period is a time of much anxiety for many mothers, and clinical postpartum anxiety is more common than depression. Apart from the child-related anxiety, which I shall deal with shortly, the most common themes are a fear that mothering will be criticized and a fear of the lack of support. Obsessional rituals and anancastic traits may worsen during and after pregnancy, and an Italian study found that pregnancy was the most severe cause of aggravation of obsessionality. As in the pregnancy, a shame over postpartum appearance, breast enlargement and abdominal swelling may lead to social avoidance. The psychoses are the subject of the 2nd presentation. There are over 30 distinct disorders, most of them rare neuropsychiatric disorders, but there are also several forms of non-organic psychosis, of which the most common is postpartum bipolar disorder. As for the child-related disorders, they include 2 forms of infant-centered anxiety, obsessions of child harm, delusions involving the child, and bonding disorders, especially emotional rejection of the child. Now, infant-centered anxiety may take the form of fear of the baby or fear for the baby. Some mothers, especially isolated first-time mothers, feel overwhelmed by the responsibility of infant care and suffer from fearful panic, which can progress to a phobia of the baby. Perhaps all mothers worry about the safety and survival of the baby, but some do so to a clinical degree, and the most severe is the fear of sudden infant death, which can be excruciating and exhausting. Phobia for the baby was described in the early 1990s. A study of 66 mothers admitted to the Adelaide Mother and Baby Unit, including 9 who avoided the infant. Some were unable to remain in the same room as the baby. And this is based on fearful panic or obsessional impulses to harm the infant. The treatment is by gradual desensitization, starting even with the sorting out the infant's clothes. The pathological fear of cot death was also described in the early 1990s, and this is the first case. For 5 to 6 months after the birth of her daughter, a first-time mother felt constantly terrified and tried to stay awake to make sure that she was still breathing. And she wrote, "As I was so convinced that she was going to die, I began to think it would be better if I killed her. I would be in control of how she died. She would die peacefully. It would limit how much her inevitable death would affect me and put an end to how awful I felt." Now, these mothers suffer not only from severe and persistent anxiety, but also extreme sleep deprivation. And the first step in treatment is for the mother to sleep under sedation while someone she trusts cares for the infant. And when she's recovered her balance of mind to some extent, a clinical psychologist can work with her on how to deal with an anxiety about an extremely uncommon event. Among the obsessional phenomena complicating pregnancy, obsessions of infanticide was one of the first postpartum disorders to be described. Chapman in the 1950s wrote this about it: "These mothers obsessively fear the murderous act. They fear they may stab or decapitate the child with an axe or a butcher's knife or sharp scissors. Elaborate fantasies accompany the obsessions, standing over the bloody, mutilated corpses, newspaper headlines, the shock and distress of husbands and relatives. These impulses, for example, throw the child into the fire, besiege gentle, devoted, and scrupulous mothers, and must be distinguished from the aggression and rage of rejecting mothers." Now, the bonding disorders are the subject of the third presentation. They are the disorders with the most severe effects on the infant. Before I leave the knowledge base of this specialty, I want to mention an interview which has been developed. It is the product of 2 workshops. The first held in Birmingham in 1998. The team was composed of psychiatrists from China, Germany, India, Malaysia, and the United Kingdom, and a psychologist from Finland. And the second was held in Stafford in 2014. And a team equally composed of psychiatrists and psychologists were from 8 nations: Australia, Egypt, India, Italy, Mexico, Spain, Sweden, and the United Kingdom. Now, the Stafford interview has been developed over the course of 20 years by experts from 13 nations. It takes about 2 hours to administer. It thoroughly explores the social, psychological, and medical background to pregnancy and the puerperium, and its psychiatric complications. It's useful for clinical assessment, training, and research. It provides the data for a thorough diagnosis and planning of treatment. Conducting even a single interview can be a useful experience for a trainee. And it's useful for research of various kinds because it's been translated into 12 languages: Arabic, Chinese from the People's Republic, German, Italian, Japanese, Mandarin from Taiwan, Norwegian, Polish, Portuguese, Spanish, Swedish, and Turkish, It's useful for transcultural studies because it has a prepartum and a postpartum uh, um, sections. It is useful for cohort studies, and it will provide the interview component of a thorough research diagnosis. Now I turn to the specialist services. An ideal specialized service, and there may be none in the whole world, would include a specialist multidisciplinary team, a community service, a day hospital, facilities for conjoint admission of mother and baby, an obstetric liaison service, links with other agencies, especially child protection, liaison with voluntary organizations which have played such a helpful part in this specialty, medico-legal expertise, and contributions to research and training. There are many styles and settings for the clinical practice of this specialty. The quality of the service depends not only on resources and teamwork, but on the acumen of diagnosticians. Its essence is the core knowledge, and it can be practiced by a professional of any discipline working alone who has acquired this basic knowledge. And a person with this qualification working in a town of moderate size, a distance away from a major unit, would be an immense asset to the mothers. Now, community services have various components. They can include a consultation service, consultations to primary care, to obstetric hospitals, or social service units. And this only requires an administrative office with the secretary. It can provide outpatient ambulatory service, which can be dispersed on several sites. It should include a domiciliary assessment, so helpful to mothers who find it difficult to travel, and providing a special quality of interview because the visiting consultant or specialist sees the mother in her own environment. It's very helpful for the follow-up of inpatient and daycare, and even severe disorders can be treated at home, provided there is sufficient support and enough staff for daily visiting. Day hospitals are an excellent way to provide clinical care in this specialty. They are inexpensive. They are much less disruptive to family life than inpatient units. Mothers benefit from meeting other mothers, but they do require a capital input. It is necessary to have enough space for mothers to meet together and perhaps have meals together and for group therapy. And there must be a creche with additional nurses or nursery nurses to care for the infants when the mothers are in treatment. Day hospitals are suitable for all but the most dangerous cases. Now, inpatient mother and infant care was pioneered in the 1940s by a psychoanalyst, Tom Main, published in 1958, and also by Gwen Douglas in 1956 in London. Both of these were in the London area. And they are a great asset. It is possible to treat dangerous disorders, suicidal depression, the psychoses, treatment-resistant bonding disorders. And the alternative is the admission of a mother without her baby to an unspecialized general psychiatric hospital. But there are dangers in admitting an infant to a psychiatric hospital. Infants have died on these units, and including one killed by another mother. We these are uncommon events, but we don't know how common they are because there has been no inventory of violent incidents and no research into these risks. In order to safeguard the infant, it's necessary to have a generous supply of nurses day and night and at the weekends. And this makes them among the most expensive psychiatric units, comparable with intensive care and forensic secure units, costing about €1,000 a day. And cost-benefit studies have not yet been published. Nevertheless, a number of nations have concluded that these units are worth both the cost and the risk. And perhaps any nation with at least 5 million population and 50,000 births a year should have at least one unit. I want to end this presentation by mentioning an initiative which was taken in England in the 1990s. Visits were arranged between units. Now, these are not accreditation visits. All staff that could be spared visited a particular host unit to see its facilities, meet colleagues, and learn from each other, especially by case presentations. And this idea was taken up in northern Italy about 5 years ago, and I hope it will be useful to other countries too. And I would also like to suggest that mutual visits between countries would accelerate the spread of knowledge. Thank you very much. Now, if anybody wants a personal copy of this presentation, they can request it by email.